At the same time, the need for mental health services is skyrocketing. We're squeezing the providers and the system to the brink of collapse. As you know, the Medicaid provider, you all heard this, a variation of this many times, so I'll try to do it quickly, but is in a nearly impossible position. There's significant and costly statutory, regulatory, contractual obligations that are non-negotiable that have to be done. The reimbursements do not provide the necessary revenue to cover that substantial cost. And there's precious little, if any, ability to negotiate appropriate reimbursement rates. In many cases, those reimbursement rates are literally decades old. So this situation makes it for a provider impossible to plan and budget for the future, as most providers are in a constant state of financial crisis. Impossible to effectively recruit and retain the needed workforce, whether direct service or clinicians, and as well as oftentimes carries an unrealistic expectation that somehow charitable contributions for a nonprofit or revenue from other programs will pick up the slack. In many cases on these programs, Medicaid is the only payer for the services, or providers only provide services to Medicaid recipients because that's their focus and their mission. However, the providers still must deliver the services. They have not been able to respond to the roughly 30% increases in wages over the past year and a half, and the nearly 10% inflation that we're also experiencing on top of that. They have no control over the labor market or the inflation, and can't pass those expenses on to the consumer or participate in inflation, as one CEO put it to me a little over a year ago. In a recent committee hearing here in Frankfurt, Medicaid officials made the statement that they've heard from every Medicaid provider except podiatrists that they need an increase in reimbursement rates. I'm pretty confident they've heard from the podiatrist by now, but I don't know that. But that statement, shouldn't that be a red flag that we're in a major crisis? So my question to you is, can you imagine running a business like this? Virtually no control over your costs, extremely limited ability to impact revenue, and when your reimbursement doesn't cover the cost, you can't make up for that poor revenue with volume. You can't. That just increases your deficit. When you're on a loss on every service provided or every client served, volume and economies of scale don't work. You're just increasing your deficit overall. So due to these factors, providers really have no ability to invest in necessary infrastructure and overhead, research and development, new technologies, or to maintain financial reserves. So, like I said, you all have heard this plight from other folks testifying to you before, and our Medicaid recipients and our providers deserve better. Which leads to the question of, why do providers do it? And what would happen if they can't any longer? Due to waiting lists for services and delays in accessing services, it's already happening in many cases that Kentuckians are not being able to access the services they need. And when they can't access the early intervention, prevention services, they eventually access services at some level, most of the time at higher level and more costly services. What we're talking about today in terms of community and outpatient behavioral health, you just put it in the context of the broader physical health. If we took away primary care providers, it wouldn't be a big surprise that our emergency room costs are going to go up. And that's what's happening here. And you'll hear more from examples specifically from these folks of how they are able to provide services with the family, in the community, in the school setting, to keep families together and to keep them from accessing much higher cost services and avoid the trauma of that as well. So the short answer is, if it didn't go away, if they don't have these services, the legal requirements and the services still must be provided by recruiting other providers or the state government doing it themselves. If you add state employees, you add big pension costs, you have bureaucracy that can't respond to changes in services as quickly as providers can. In the end, it would just cost much more than it does now. So at this point, I'm going to turn it over to Paula and let her make some comments, and then Susan will, and then I have a letter. I want to read the letter from Becky in your that's a specialty and a specific thing I want to read to you all at the end. Then I'll have some closing comments. Paula?
Hello, I am Paula Garner. I am the president and CEO of Maryhurst, and I just want to thank Chairman Meredith and Chairman Elliott and all the members of this committee for the opportunity to present on this critical issue for children in our state. I also want to just take a quick minute and have an opportunity to thank the legislature, and we've got a couple of our committee members here, Dr. Alvarado and Senator McGarvey, who helped us to obtain additional support for our 5S residential program in the last budget session. And you know, this program is one that serves kids from throughout the state. We serve kids and families with the most significant mental and behavioral health issues, with the goal of keeping them from having to stay in the hospital for long periods of time or having to go out of state for care. And we were at a crisis point, and I came to the legislature and said, we have to have these funds. We're closing programs. We simply do not have enough staff. And you all answered the call, and I'm very grateful for that. So I wanted to make sure and take an opportunity to thank you. This funding has allowed us to increase some wages. We've seen our recruitment and retention get a little bit better, and we're almost at the pre-pandemic capacity, and those are for those residential services. Some of you may know that Maryhurst is the oldest continuously running family-serving nonprofit in the state with 180 years of legacy. And Maryhurst has certainly evolved over those years as the needs of the community have evolved. And so we are at a point right now where we know that, and we are committed to continuing those residential services as long as they are needed. But we are also very committed to ensuring that those services are not needed by getting to children and families sooner. You may know, and there's a growing body of evidence that shows that children who can remain in their home or an alternative family setting have the best chances to thrive long term. I've worked at Maryhurst for 26 years, and it has been an absolute privilege. I started as a therapist, and one of the most discouraging things that I witness is when I see abuse and neglect and that cycle continuing. And I see that when we have the child of someone who's been in the foster care system come to us for care. Because in those cases, I know that the system has somehow failed those families. And I know that we can and we must do better. So in 2014, with the creation of the Behavioral Health Services Organization provider type, Maryhurst was able to launch a program that works directly in the community, where we work with children and families, in the community. Our program is called Maryhurst Renewal, and in this program, we come alongside families to provide crisis stabilization, in-home care, support in schools. We're in over 100 schools currently, public schools, and wraparound care. And our goal is to equip those families with the skills and the connection to needed resources so that we can avoid and help them avoid transmission of trauma and abuse into the next generation. Within our renewal program, we provide individual, family, and group therapy. We also provide behavioral support, so in-the-moment support. We have staff that can go into the school and sit with a child through the classes that they're having a difficult time with, for example. We provide case management, behavior analysts, and psychiatric services. Our program is on track to serve more than 600 clients this year, and we currently have about 350 active clients. We have trained, as I said, we've got trained staff and clinicians going into over 100 public schools. We have almost 80 clients pending admission, and when I talk to leaders from like agencies across the state, they also report having similar waiting lists right now. We just simply do not have enough clinicians and staff to take care of the need. But I want to clearly articulate for you what the program that Maryhurst Renewal serves. The families, they are the most complex families with the most complex needs. So just to give you a sense, I'm gonna provide a few data points. 60% of them live with a parent or guardian who has mental health issues, and that's by self-report. So we know that that's probably understated. 36% live with a parent or guardian who has been incarcerated. 1 in 10 of those we serve themselves have been involved with the justice system. Over 50% of the households are dealing with problems related to alcohol or drug use, and 70% of them are assessed as high risk on the pediatric ACEs and related life events screener. So these are families that are in crisis, and we are successfully helping these families navigate so that the kids can remain in the home, which again is our goal. This program is furthering access to services and health equity in a couple different ways. First, by focusing our services on families in the west and south end of Louisville, districts where the largest share of residents report their mental health is not good. Second, by going into homes and schools, we eliminate the barrier of transportation. And I do want to note that expenses related to transportation are not covered by Medicaid. We also, especially during the pandemic, heavily used telehealth and are still doing that now to, again, help reduce some of those barriers. What I know about the cabinet is that they have identified as a priority to move towards more preventative models of care. We know that they are committed to disrupting the cycle of abuse and neglect. However, in the 8 years that we've been doing these behavioral health services in the community, we have not seen a consistent investment in funding these services. In 2021, and I'm speaking about Maryhurst here, our average reimbursement rate for services offered in this program covered only 76% of our direct program costs. So that does not include any kind of administration, overhead, data collection to show outcomes. No, it does not include any of that expense. And last year, Maryhurst lost over $500,000 as a result of providing these services. And that's with efforts to increase efficiency, strip away any unnecessary costs, but of course, at the same time, keep our quality. So in 2022, we have had increased wages even further. So that just increases the gap beyond what I reported in 2021. And in fact, this week, I have heard that we have offered 3 mental health therapist positions, and all 3 have been declined due to rate of pay. We are looking at creative local partnerships to find other streams of funding. And we have had generous community partners who've come alongside us, like the Kentucky Association of Health Plans. They've come alongside us, and they've helped us to fill part of that $500,000 gap. And honestly, had that not happened, we would not have been able to continue all of our services into this fiscal year. And I know you may be wondering if we've talked with MCOs about negotiating rates and that kind of thing. And we have. We have strong relationships with MCOs, and I consider them absolute partner. I know many folks who are working with MCOs and have great respect for their leaders, but they have to point back to the Medicaid rate, the posted Medicaid rate. We also, I just want to make sure and say that we've been able to do a lot of grassroots events and activities and volunteerism with MCOs, but it just hasn't resulted in any kind of systematic reform of the rates. We would certainly welcome an opportunity to come up with like one value-based program that could be implemented across all MCOs. It's frankly administratively unmanageable to do multiple value-based programs with all the MCOs, but again, one program that could spread across all of them, I think is something we'd like to look into. So in closing, I will just say we cannot sustain the current business model. And I've talked with leaders from agencies, at different points of the state, and they report that they are also on the brink of closing either all or part of these services. Without permanent increases, these services will go away for thousands of Kentucky's most vulnerable children. And that can't be brought back on. It takes time to build infrastructure for these services. So if they go away, we can't bring them back in the flip of a switch. And I fear that this will have negative impact that could go into the next generation. We have an opportunity right now. Kentucky has the resources. We know that. And we have an opportunity right now, and it is up to us. It is absolutely up to all of us right now to ensure that these programs can continue and ultimately expand, because the need is expanding. I thank you, and I do thank you for this opportunity to present and talk about this important issue.
Susan?
Hi, I'm Susan Campbell-Turner. I'm with Children and Family Counseling Associates out of Harrodsburg. We serve a lot of rural counties. I'm originally from Breathitt County. You can maybe hear that coming through the accent there. But we serve primarily a rural population. So I'm not going to go into a lot of the statistics as far as what our population looks like, because I think it's pretty similar. We're dealing with families in crisis. We have children who have parents who are in jail, who have mental health crises. We provide individual family therapy. We provide psychological assessments. We provide batterers intervention program. We provide after school group. We provide case management. So we do all of that. In 2019, we provided about 80% of our services in the homeschool and community. Things have changed a little bit with telehealth. Maybe about 10% of our services have gone to telehealth, but we still provide, we estimate about 70% of the services that we provide in the home, in the school, and the community. So like Paula said, none of that transportation cost is reimbursable. So just to give you an example, and I'm not gonna repeat a lot of what Paula said, but as a clinician, so I run the agency, but I also see clients. So that's my primary job, is to see clients. And that's what y'all should want me to do. You don't want me to do other things. You should want me to be serving these clients. So last week, I got a call from a school that I work with. Kid has made self-harm statements, kind of one of those, mom's going to take my PlayStation, so I'm just going to kill myself, right? So they were going to send him to the hospital. I said, let's not do that. Let me come out. Let's see what we can do. So I went out, saw the kid, saw the parent, talked to the guidance counselor, crisis averted. I go back to the office, write up the note. About 3 hours of time is spent doing all of that, talking, moving. I can bill for 1 hour of that time. So when you start to think about how hard that is for providers, it's like a typical day. It's pretty common for me to work about 9 hours and be paid about 5 or 6. Who wants to do that? I don't blame your people for saying, no, I don't want that job. Paperwork has never been more burdensome. On Tuesday, I spent 3 hours signing other people's paperwork. Why am I doing that? Why am I sitting around signing other people's paperwork? My program director, my clinical director, we all have to set aside 3 hours every 2 weeks just to review and sign other people's paperwork. All of us have more than 25 years of experience providing therapy. Why are we sitting around doing that while we have a wait list of people who need these services? Why are we doing that? But what I'm going to just talk to you just quickly about, that I know Paula's group is probably having difficulties with, all of us are having difficulties with it around the state, is audits. They are literally never ending from the MCOs. Literally every week we get another audit. So what I'm going to tell you about is just in the last 10 weeks, we put a 60-chart audit in the mail on Friday, August the 19th. On Tuesday, we got another audit from a different MCO, and they wanted 280 dates of service going back to 2018. Now, in my office, when you're talking about charts that are 4 years old, we have an attic, and I literally have to climb the ladder, pull out the dusty box, get it down, come down, copy the data service, the psychosocial, the treatment plan, all the assessments, put that in a pile, climb back up, find the next 280 times. I'm entirely too old for that. Why are we doing this? 280 dates of service. So we put that in the mail on a Thursday. The next Monday, we got another audit request for 10 full charts. My office assistant cried when we got that in the mail. It's what we estimate to be about 7,000 pieces of paper that we now need to copy and then upload and send to an MCO. I have 5 administrative staff people. We are doing all that we can do to answer calls, to get billing out, to get this stuff done. So now it's me and Michelle, who cried, trying to put all of this together. On the way here, I got a call from the office saying, we got another one. We got another audit request today. What are we going to do about this one? Okay, so that's what we're doing. During the first week of August, we were told that all of our claims for case management for the month of July were being held for what they called a prepayment audit. Okay, now for us, that's about $20,000. That's how I pay my staff. That's how we pay our house payments and car payments and taxes and all the things that we have to do to be participating members of society. So I start calling, what can we do? You know, I'm originally told that, so case management is a service that's billed monthly, so we bill it on the last day of every month. July 31st happened to be a Sunday. They were withholding all the payments for that because it was considered unusual billing because it happened on a weekend. Okay, so that's what I'm originally told. We are told that we have until December to submit these claims and that they then have 90 days to pay us, just to decide if they're going to pay us. So we're talking about March payment, possibly, for services that we provided in July. No business can operate like that. You just can't operate for it. So I put in lots of calls. I screamed at a lot of people. I was not very nice about the whole thing, and I apologize if any of you were people I called, because I called a lot of people. And so we were told that they would expedite the process. Go ahead and start uploading those records. Okay, so we start uploading records. We get 4 records uploaded into the system, and I get a call that says stop. There was a scripting error. We don't really need your records. Go on about your business. It took us weeks to get payment. Today, I still have 1 claim out of that batch that has not been paid. Had I not called, been not nice, we still certainly wouldn't be paid for it. We'd still be kind of in this loop that, again, seems never ending. Final audit story. I could go on. If any of you have the rest of the afternoon, I could tell you a lot of these stories, but this one's pretty critical as well. And again, this isn't just us. This is across the state. These things are happening. In May of 2021, we got an overpayment demand letter from one of the MCOs. And at that time, I called you and we talked, and I called you, Representative Winter, and we talked because I was like, what in the world, you know? So at the same time that we got So that MCO had reviewed records and deemed 0% of the services that we provided were eligible for reimbursement. At the same time, we had had an audit from a different MCO, same time frame, same records, same format, basically, and we got a letter from them. We got 2 letters saying we got a 96% and a 97% on that audit. I don't know why I lost the 3 or 4 points, but you go from 96, 97% to 0%, same paperwork, okay? So I consulted with an external billing and coding person because I want to make sure that we're doing the right thing. We really do want to do what we're asked to do. We're very invested in making sure that that happens. That person actually wrote the coding and billing manual for the Children's Alliance for the state of Kentucky. So reached out to her, what's going on? She looks at the records. She says, you should appeal this because you're doing everything that you've been asked to do. So I submitted several appeals. The last one, my final appeal, was sent in on December 6th of 2021, certified mail. They had 30 days to reply to me. On July the 8th of 2022, I got a letter from them saying, hey, we got your letter. We're going to send that out for review. I called when I was talking to them about the audit that we got. I said, did we get anything today? As of today, whatever today is, the 13th of October, we still have not heard anything. So we are 10 months from our final appeal, and we are 18 months since we started the appeal process. So at that point in time, I really didn't have any other choice but to stop providing that service, right? So it's a community support associate service. And we now have a wait list because I don't know what the expectation is. No education is provided for providers to know what are we supposed to be doing. We think we're doing the right thing. We hope we're doing the right thing, but we get a 0%, we get a 97%. Where'd that come from? I cannot, as a business, sustain that if I have constant increased administrative costs. I have constant, these audit exercises are constant. They're never ending. Recoupments, when are they coming? I have no idea. I cannot operate a business like that. As a provider, it feels like we're in a no-win situation. The target is not defined for us, and it is always moving. We have no idea what's coming next. So I'll finish. I do want to plead for you to come to the aid of the mental health professionals. We are at a breaking point. In the past few months, I have seen 4 master's level clinicians leave the field. One of them's working at Kroger in the meat department, living in a storage container. One of them is working in retail. One of them is a bridal consultant. And one of them went to be a teacher's aide. This is just my little circle of what I am seeing. This is happening across the state. I am thankful to be more at the end of my career than the beginning of my career because I wouldn't suggest that my children go into mental health. There's no security there. And while we're doing all of that, I'm seeing more need than I've seen in the 30 years that I have been providing these services. So, thank you all.
Thank you all. I just want to touch base. Thank you, Susan, so much. I just want to read briefly. You all have in your packet a letter from Ms. Nastali. And I chose her to write this. I was hoping to get her to provide testimony, but given the short turnaround, and as Susan, she sees clients, she lives in Paducah. Senator Carroll knows that's a long trek to cover to get here and back. So, and so I asked her to just write a letter, and you all have that. I'm not going to read all of it to you, but I just want to read an excerpt because as a provider, they face all these same dynamics. They bill off this same fee schedule, but I just wanted to point out the impact on this particular population of very small children with diagnosis with autism that go on a waiting list and have to wait. I mean, when you need mental health services, you need any health services, you need them now, not a year from now, not 10 months from now. But when your child, we can, and I'll just read from her that, at 18 months, we can diagnose this as early as at 18 months of age. Effective and specialized treatment can allow therapists to help establish communication and social interaction to prevent the development of a host of challenging behaviors that, left untreated, can lead to dangerous outcomes. If people can't access services right away, the challenge becomes undoing those dysfunctional behavior patterns. So she wrote that she recently began therapy with a child was already 5 or 6. Rather than starting at the age of 2 is a whole different ballgame. She started one at 9 a few weeks ago, and while I hope to have a positive impact on this young boy's life, I look at him knowing precious time has been wasted, and he had the chance to access treatment earlier on. There would be a whole world of opportunities available to him that now may not be. People with autism can go to school, they can have friends, they can live on their own, and their families can go through life without enduring the stress, worry, and suffering that comes from wondering when the next crisis of their child will occur. So, and you all can read that. I don't want to read the whole letter to you. But the point being is that at that very early developmental stage, early and active intervention can be so critical for the trajectory of their life. And if they're diagnosed at 2.5 and they don't get services until they're 4 or 5, then you've missed the critical area of opportunity, and you're playing catch up from then on. And I know that's true in a lot of areas of mental health, but I just wanted to kind of point that out, that that's a specialty service that's on this fee schedule as well, and really has a particular point with young folks. So I'm going to close. I know we've provided a lot of testimony, longer than I promised it would be, but the good news is that, so I want to leave on a positive and a request. The good news is we have a solution to all this. You have providers that you've heard from today that are willing, that are trained, that are passionate about this, and want to deliver these services to help our citizens and your constituents. It's a simple. We had this during the session. It was a $16.5 million request for state general funds that, when paired with federal match and the Medicaid program, can enable a 25% increase for the rates on the whole fee schedule. $16.5 million state general fund dollars. Now, we got that number back in February, which was designed to address the workforce crisis. Fast forward a very few months, and I can't say the 25% today would actually solve it, because we've had continued workforce and nearly 10% inflation on top of that. However, that's our request. We also need to have a mechanism that if that's funded, that goes through the MCOs, that's passed on to the providers. I've talked with lots of MCOs. They're not opposed to increases, if they have the funds to do it. But the other piece of it is, which is kind of a unique situation we're in, we just ended the second year in a row with nearly $1 billion surplus in our state budget. I've been doing this for 25 years. Most of the time it's been about money for providers, frankly. And we're stretched thin. We're making reductions. We've been through after the recession, when we cleared out $1 billion of the budget just to stay balanced. But we're at historic surpluses, and we need to address this crisis. We have done, over the last several sessions, we have significant investment in the state employee and the teacher pension systems. We've set our state on a path to reduce and eventually eliminate the state income tax. We've had hundreds of millions of dollars in significant economic development in industries. We've increased funding in this past session for K-12 and universities. We've increased wages for state employees. We've done disaster relief funding for Western Kentucky tornadoes, Eastern Kentucky floods. We've invested in dealing with the pandemic and the healthcare and the public health precautions, all of which we absolutely needed to do as a state, and good to meet the needs of the citizens and to put ourselves on a stronger fiscal ground moving forward. But now is the time to address this crisis that has not been addressed. So that's our plea for you today.
Appreciate that, and appreciate your testimony. It's been very interesting. Ms. Turner, also to you, I didn't denote an accent at all. You sound just like one of us. But I probably should tell you that we're going to bill you for this counseling session. I hope you feel better.
Yes, I do.
Excellent presentation. You really did. I've always enjoyed speaking with you. And certainly we're looking for solutions to this. And maybe one is that since we haven't heard from the podiatrists, we're paying them too much, and we'll reduce that. No, that's just a joke, everyone. The podiatrists provide an invaluable service to us, and they just haven't come to the table yet. But, yeah, we need to address this. One of the things that I've heard throughout this interim session, almost every committee, is this explosion of demand for behavioral health services. What do y'all attribute that to? Are we doing a better job of recognizing behavioral health issues? Or is it just, what is it? Why are we seeing such an explosion?
Well,
I'll let the clinician.
Okay, yeah, I mean, I think Susan will have, opportunity to offer some great insight as well. But I would say, I mean, certainly we all know and we've seen it and we've lived it when we went through and are going through the COVID pandemic. I think there was a huge need before that, but I do think that the pandemic exposed the cracks that we already had in our communities, and that folks on an individual and in a community level have in terms of needs for mental health. I also think, and this, I'm thankful for this, I think it kind of destigmatized, getting mental health in some cases, because we saw other people doing it. And so I think that is part of it. I mean, and certainly you had kids who were not going to school for long periods of time. You had social isolation. I mean, you had a number of factors that I think exacerbated factors and needs that were already in the community, but they maybe just escalated those a little bit more. And so that's one answer I would offer. There are many, but that's one I would offer.
Well, thank you. Appreciate that. And Ms. Turner, your discussion about the audit always sounded very interesting. And in your humble opinion, do you think maybe we'd be better served, our Medicaid program, if maybe we only had 3 MCOs rather than 6? And
Yes, sir.
so sorry, that was a leading question.
Yes, sir. Yeah. I mean, it's impossible to, 3 would be a lot if they all have different rules. We have to do the same thing for every client. We can't treat, this one this way and that one that way. We have to do the same thing for every client. So when we have to even just credential a new clinician, we have to credential them with Medicaid, and then each MCO has to be credentialed with. So we're talking sometimes 6 months to get a new clinician.
Yes, ma'am. I think the last number I saw, they're spending 16 cents of every dollar in America on the administration of health care. It's double what other industrialized nations are spending. And that's a source of funding right there. And Bart, I have to take a little bit of issue about our surplus. That came large measure because of federal dollars we received during the COVID crisis. Sure. And when this recession hits, and it's going to hit, we're going to maybe see some draconian cuts in spending, and certainly don't want that filtered down to our healthcare providers or any service that we have. And so that surplus that we have there, we best be protecting that. Plus, the other issue is ongoing. Yeah, we can pay it out of surplus, but then what happens the next biennial when those federal funds aren't there? So we've got to look for a better sustained revenue model than we have. And we think we're on that with the legislation we passed this last session with the transitioning from income tax to broader based consumer tax, but we're getting there. But
I agree with you, Senator Meredith, that this is an ongoing, we need a systemic long-term solution to it, that pulling, doing something out of a one-time surplus that, like you said, certainly direction looks like that's not going to be the case every year moving forward, no question. But I think that we do need this, and that's one of the things that, we have a request now, but really the long term is to really look at what the cost of delivering services and what the needs are and funding those appropriately long term. I mean, had we done that the last few decades, we wouldn't be where we are now.
True. And Ms. Garner's correct. I think COVID really exposed a lot of weaknesses we had, not just within healthcare, but throughout our Commonwealth. With that, we got several questions. Senator Alvarado, you're first on the queue.
Thank you, Mr. Chairman. Ms. Turner, I'm part of the choir, so I appreciate all your comments. This is something that's been reiterated here for the 8 years that I've been in office, is the same complaints, and unfortunately it hasn't changed. You can interject whatever provider you want, pharmacist, primary care doc, a nurse, just interject it into your testimony, and it applies to everybody across the board in healthcare right now under a lot of the MCOs. And I've gotten to the point where we talk about reducing them. I'm talking about eliminating them. I'd like to know your opinion. You've been at this a little while. Were things better when we didn't have MCOs, as far as you're concerned, in terms of your bureaucracy and being able to do your job?
Certainly there was a lot less bureaucracy, and you had one set of rules and one set of guidance. You didn't have 6 different entities telling you 6 different ways that they wanted things to be done.
Right.
So, yeah, absolutely.
Yeah, and I think that's true. I preach it. After a while, I become part of the wallpaper here, and it's just, Alvarado carries this group's water and says these things. I think it's important to hear from real providers that come here and reiterate, what I experience, what I see happen, because it's real. And I think, you have to wonder how much of a tax the MCOs have become on providers, because they become a tax. We don't take, there's not money that gets taken out from the government, but we've established another entity to take that money away. And it's found that it's taken away not only in these audits to say, hey, look, prove to us that you didn't rob from us before, from 4 years ago or 5 years ago or whatever. These ridiculous letters that are 1,100 pages deep by some of our MCOs saying, here's all these accounts, show us that you didn't steal from us. If not, we won't pay you. We want the money back in the future. That's nonsense. That's just bad business dealings by a bad business partner. People want to know why providers have burnout. This is why providers have burnout, is what I would argue, is this nonsense, is how much time is spent proving that we're not thieves. And I know there are thieves within healthcare, unfortunately there are, but we're basically burning out the entire profession from top to bottom in all aspects by asking them to prove that they're not crooks, that they're not stealing, and having to do all this incessant bureaucracy. Senator Meredith and I have discussed this before, that there is enough money in the system now to provide the care that we need. There is enough money. You take away the time that's required from these folks that are having to spend their time doing this and put them into clinical care to see patients and take care of them, would take care of this. Electronic medical records, which is supposed to make things easier for us, has become a headache. I can tell you, I went from, people here know me, I work pretty hard. I could see 25 people in 10 hours in my office in the past. When EMR came along, I went to 16 people in 13 hours. So I spent 3 extra hours. I get home at midnight instead of at 8 or 9 o'clock at night, just inputting data. Why? For insurance companies and for government. Did it provide better outcomes? No, it didn't. So all these things are taxes on our providers that we have to understand. And your kind of testimony kind of confirms that. And I would argue that, again, we've put a lot of money into healthcare. We've expanded Medicaid by the request of providers. We have an expansion of Medicaid. There's a lot more money that the state is putting into that. There is money that's there already. We're finding ways that our MCOs are using those. They're finding ways to take monies out behind the scenes that we haven't seen. PBMs are an example of that. Lots of it. So, I appreciate it because you're real. You come in here, you express the frustration. And like I said, I could apply this to every provider in the system. And our MCOs, I know here, and they've heard me complain about it a lot, like I said, but really it's gotten to the point where you have to wonder, are they really even worth it? They're not really providing us anything. And I think they haven't shown us improved outcomes over the years. All they do is create this. If people are willing to go work at Kroger's and retail instead of providing clinical, that is a sad state of affairs.
It is.
And I can tell you there are doctors that I know that are now truckers, frankly, enjoy being on the road. They're listening to a radio show and just being able to, drive. They get paid well, not like they did for a doctor, but they had a smile on their face again, and then having to deal with all of this, and it's sad. So thank you for the rant, Mr. Chairman. I appreciate it. You know me, I can't let this go. But it's real, and I think we have to look at this as a tax we've created on providers. I think if we view it that way, that the time, it's not tax necessarily on money, it's a tax on time, which eventually translates into money for providers across the board. Thank you.
Thank you, Senator. In in the interest of fairness and showing we don't discriminate, we'll be charging you for a counseling session as well. So.
Listen, this is why people wonder why I lose money being a doctor serving in the General Assembly. It's for the therapy. Thank you, Mr. Chairman.
Representative Sheldon, do you need a counseling session? You're next.
I would like to ask the price before I go, if you don't mind.
We'll work something out.
Just Medicare allowable will be all right with me. Let me just kind of piggyback a little bit. I can't not possibly rant any better than Senator Alvarado did. But he was right on. The irony of it, I just couldn't help but hit me. As and Ms. Turner, you're in the trenches, so you understand. And I heard in your voice and how much it hurt to deal with all these audits. 2 or 3 real quick questions. Are the audits desk audits, or are they are they just sending you random claims and you're having to explain those claims?
Yeah, it comes in the mail, and then we have to mail it back.
So they're not on site. They're just simply just send it out to satisfy a quota. Okay.
Correct.
We see that in every area of healthcare, and it's bureaucracy at its worst. And now what Dr. Alvarado said, well, they're sending you all this stuff to make sure you're not taking money from them. And then you said you had the same claim with 2 different MCOs, and one said it was great and the other didn't. Okay, it leads right into, well, the irony of all this is that we have MCOs that in the last 3 years have paid out over $500 million in settlements because they defrauded Medicaid in about 14 states. That's just one lawsuit. That's just one lawsuit. It was, it's up to 479 million, and they've already put back 1.2 billion more because they know more is coming. My point is, the irony of them sending you these audits and keeping you busy and keeping you distracted, and eventually paying after 6. And let me ask you this last question: do any of them? What is there an MCO out of the 6 that you deal with primarily? I mean, like, is your number one, number two?
Well,
stands out.
Yeah, let me say 2 things. So just that one audit, I personally probably have 75 hours invested in that. So I could be seeing people. I'm a trained clinician.
Right.
I should be seeing people. And so for us in our rural area, I would say of the ones as far as percentage of people, probably 30 and 30% with Aetna and WellCare, and the rest it kind of falls out a little bit from there.
Okay, I was just curious.
Yeah.
And thank you very much. It's
Yes,
seen
sir.
in every single thing, but I'm sorry for all those audits, and maybe one day they'll slow down and take care of their own business. Thank you.
Thank you.
Chairman Meredith, can I make just a quick comment?
Yes, please.
Quickly on the audits. I think one of the things, because this came up in Child Welfare Oversight and Advisory Committee yesterday. I'm going to ask Michelle, who's the director of the Children's Lines, did a nice testimony yesterday. I'm going to ask her to send that to you all, her PowerPoint, because it covers some of the similar pieces. But one of the things is all these claims-based audits, they all go back through Medicaid. So I mean, and I've talked with Medicaid. They held off on audits during the pandemic. CMS is putting pressure on them. They turn around and put pressure on the MCOs, and so we're seeing all this makeup time for these audits. So it's kind of it's a systemic issue, and it's over, but one of the things, and I don't know, I haven't vetted this enough, but all the claims end up going back through Medicaid anyway, so why is it that each MCO has to do audits on every provider? Why can't that claims database from Medicaid do some random audits for a provider? And that way it's one entity, not 6 trying to do it. So that's just a thought. Like I said, I just haven't vetted it enough to know if that's realistic, but it's just a thought. So,
the answer is it's not about the money, it's about the money. Senator Carroll, how's your mental health today?
Yeah, I don't have enough money here to pay for the therapy that I need.
A trauma-informed discussion here.
And I'm not going to repeat the stuff about the MCOs. Every year they come in, they tell us how great they are, and there are some that do better than others, but there's no doubt about that. But folks, I'm telling you, it's on us to do something about this. We can't keep putting this off on the cabinet. They're not going to do it. So we have got to get some legislation passed to take care of this. We are beating this system down, and it's something we could have a major impact on. And one MCO came in. We're going to be great. We're going to set the standard. And you all have heard me say this a million times. We do very basic services. We do PPEC services. We do EPSDT therapies. That's it. It took us a year to get payment. They were $60,000, $70,000 behind, almost a full year to get anything. And we go through, like you said, and that it's the same thing. And there is not a doubt in my mind that some of these MCOs have a systematic plan to avoid delay payment. I don't know if it's an interest thing, and you've heard me say this before, where the longer they get to keep that money, the more interest they can draw on it. But it's so blatantly obvious, and we got to do something about it. In Dr. Nastali, and I wish she could have been here today, she provides great services down in Paducah. My organization is in the process of building an autism center. We're 6 months away from opening it. We've been going through the process of negotiating, and we're getting into private insurance as a nonprofit. We've never really done this before, but we're going through that. It is infuriating. You can't talk to anyone else to see about what rates they're getting. I've got one MCO that wants to pay private rates and for some codes less than what Medicaid pays. So building a business plan and trying to figure out what you need to sustain the programs, you can't do it. And we're not going to be able to take, we'll be able to take a certain percentage of Medicaid kids. So it's a balance that we have to obtain, and you can't get anything more than the Medicaid rate from an MCO. That's the basic, and it's just not going to happen. So all of that is very frustrating. We're 6 months away. We've already got 50 kids on our waiting list. Already have 50 kids, and that's where, that's the struggles that we have down in Paducah and that area with the need down there for autism services. And the system it's an obstacle, it's a deterrent to open up these services because of all the bureaucratic crap that you have to go through. The constant denials, the constant, 5-6 codes that we deal with. Every other year they just forget what those codes are, and we have to go through the same song and dance. You all are using the wrong codes. Tell us what code. Well, I can't tell you that. And it's just an all systematic game, and it turns my stomach every time they come in here and try to convince us how great they are and what they've done for the health of this state and how they take care of kids. They go out and do some of these programs every once in a while that are really great for marketing, but the job that they're hired to do, it's not getting done because it's providers that accomplish all the things that we need to do. And we're making it worse on providers. We're not helping providers out. We're creating more bureaucracy, more red tape that causes have to spend time doing stuff like that for no legitimate reason. But we've been through it too. Went months having to appeal, fight it. Took $70,000 that they recouped. We finally got it back, but it cost us probably $20 to get that back.
Right.
And it's every year we go through this same song and dance. We have got to do something about this. And Senator Meredith, Mr. Chairman, that bill to narrow it down to the 3 best, that's got to happen. That has got to happen. Dr. Alvarado, if we want to get rid of them, I'm for that too. But I do think it wouldn't be a bad idea to give some of them a chance, because we do have a couple that are good, and they do try to help, and when you need something, they're there, and I think they do make an effort. But 6, it's ridiculous, and I'll put that on my bill. I'm going to have to make a payment plan. I'm sorry.
Well, I'm going to apologize to Co-Chair Elliott and Representative Prunty because we're running short of time. We won't be able to provide you an opportunity for a counseling session, but maybe afterwards we can do this. But we have 2 more, and please let's be brief because we got one more presentation. Representative Wilner.
Thank you, Mr. Chairman, and thank you, Co-Chairman, for having this presentation today. This is so important. Every day I'm hearing about the increased need for mental health services, and I am hearing from every agency, every provider that I talk to, no matter what type of mental health center it is, about professionals vacating the field. Yeah. And Senator Meredith, you talk a lot about when we think about the cost of things, we have to consider the cost of what we don't do. And the cost of not investing in the mental health workforce is so dire. I mean, it fills me with existential dread. I'm awake nights, literally, thinking about this. And you're right, once they're gone, we can't conjure them up magically. And for you, Susan, who's invested decades of your life into this career and served so many people, that you're willing to keep doing it despite these headaches, we can't expect young people coming in, young professionals coming in, to be martyrs to the field. And we've got a state that's hurting. And so your proposal, Bart, for the $16.5 million, and I agree with Senator Carroll, we need to do something. And that's something that we can do as a legislative body, is to make that investment in our mental health services. And I hope that we will take that call to action very, very seriously, because not doing it, we can't afford it. So,
Hear, hear.
thank you.
You know, in the hospital world, that if you have a readmission within a certain time period, that goes against your quality score. Senator Alvarado has asked to speak again.
I'm just going to say we are working on, Greenwell is a repository for a database for Medicaid. That's the company that contains, they don't do much with that data. It's just kind of in different piles. We're working on an all payers claim database bill that we're looking at using them to be able to compile that information to give us the data that we need, that our MCOs, when we've asked them, say, well, we don't know what to improve. You tell us what you want us to improve in terms of quality measures. And I said, well, I thought you're the ones that are managing care, not just managing money. So since they don't know how to manage care, they want us to manage the care for them. I need to compile the data. We're looking at trying to get that company to use that. And there is a bill, when I first got here, Senator Carroll, on fixing this. It's a thick bill, big one. I got it in my drawer. It's still there. So it would be something that be able to bring back out and try to talk to other powers that be within the General Assembly to be able to loosen that up. But I think it's time. I mean, this has been 8 years. I've been having this discussion 8 years in here, complaining, exposing a lot of this stuff, sometimes dragging information out of our MCOs to show where they've been abusing the system. I'm tired of that. I mean, at some point you just say, look, I got a bad business partner. It's time to fire the business partner, terminate that relationship, and do something that's going to work. Because it's just not worth the mental health of our providers and the sustainability of our providers across the board. The burnout is from this. That's what it's from. Thank you, Mr. Chairman.
Sorry, that's another bill. Thank you all for being here. This has been a great discussion and very enlightening. And obviously, you've got our attention. And as we proceed forward the next session, and since we're not in a budget session, we're not sure what we can do this go around, but you've got our attention. I can assure you that.
Great.
So thank you for being here
Thank
today.
you so much. Appreciate your time.
I'm going to mention to my committee members that I don't talk a lot about this, but I have mind reading capabilities, and our next presenters are thinking, we wish we'd been first on the agenda. So if you gentlemen want to come forward, WellCare will be our fifth MCO out of 6 who has presented, working from the same format of 5 basic questions that we've asked of them, and they're here today to address that. But
Good morning.
good morning. If you would, introduce yourself for the record. Feel
Yes,
free
sir.
to proceed.
I'm Corey Ewing, Coreyewing, Plan President for WellCare of Kentucky. Thank you, Chairman and committee members, for allowing us to come today. I'll let my teammates introduce themselves.
I'm Chirag Patel.
Turn up.
Chirag Patel, Chirag Patel, Patel. I'm the Chief Medical Officer for WellCare Kentucky.
Good afternoon. Good afternoon, everybody. I'm Darren Levin, DARREN LEVITZ, and I'm the Director of Member Experience for WellCare.
Glad to have you here this morning. Feel free to proceed.
Thank you. Well, first, I want to thank the ladies that presented before us for what they do provide to our members, because they do provide a fantastic service that many of our members do receive and need. And I also wanted to thank them for warming the committee up for us. With that, just say thank you for inviting us to speak today. We're certainly glad to share with you some of the things that we're doing around the questions you asked us to answer and the initiatives that we are doing around those and the associated outcomes with those. Next slide. One of the things that we're tasked with is making sure that our members go to the PCPs for their primary care needs, not the ER. That's one of the things that we're definitely tasked in. That was actually mentioned in the previous presentation. Overall, we've seen a lot of success with that, but we wanted to dig into the data a little bit deeper. And there's one thing that we all know exists, we just don't talk a lot about it, is member churn. We see members that move throughout the MCO universe, but we wanted to take a hard look at those that have actually been with us for a consolidated number of years. We picked 2016 as our baseline year. Nothing special about 2016. We just thought 6 years was a good time frame. So if you look at the graph there on the left, it shows a pretty consistent downturn in ER visits, and this is just for primary care visits. And the inverse is also true on the other graph. We've seen a uptick in average PCP visits every year over the baseline year. So definitely an interesting dynamic, but that can't happen without consistent care management and a strong network of providers to send those members to. So next slide. You can see that we exceed the contractual requirement of 95% access threshold for all provider types, and we met the target over 100% for hospitals, CMHCs, and for PCPs. Next slide. Just real quickly, in the same theme as network adequacy, just access in general. There was a lot of discussion in the previous presentation about telehealth. I wanted to say thank you to Senator Alvarado and Representatives Prutney and Wilner for your work with telehealth, because it has truly opened up a whole nother world for our members for access. To date, we've paid over 12,000 distinct provider IDs and 89 unique provider taps just through telehealth. It was kind of interesting. I saw the trend that when I got here to Kentucky, I saw this same trend when I was a hospital CEO. Wasn't a really strong adoption in telehealth until the pandemic hit, but once it hit, we saw a tremendous increase in use, and I think we all see what it can do for our members and the residents of this state, and it's not going anywhere. It is now probably a permanent part of our provider and healthcare delivery tool belt. So thank you for the work there. And then again, to emphasize that, I want to talk about two studies that kind of really strengthen the argument for telehealth. Deloitte did a study a few years ago because a lot of people asked, do Medicaid beneficiaries even have access to a digital device so they can participate in telehealth services? Well, Deloitte studies showed that 86% of Medicaid beneficiaries have a smartphone and right at 70% on a tablet, so not that vastly different than the general population. And then just as recent as this summer, Journal of American Medical Association did a similar study specifically around behavioral health telehealth in rural counties. So what they showed is there was about a 14% increase in post-discharge visits with that behavioral health population just because of telehealth. So again, thank you guys for the work you've done around telehealth. We fully support it. Next slide. Appointment availability. This is also something you guys wanted to hear about. The only place that we were under 95% on appointment is those calls that are returned within 30 minutes after hours. Next slide. We have a significant amount of interaction with rural providers because a little over 75% of our membership lives in rural Kentucky. So we have to spend a lot of time with those folks, and I don't have to tell you guys about the hospital rate improvement program. You already know it, but because of the MCOs being here, the federal payment limit is higher. Last year alone, we passed $351 million along to the hospitals here in Kentucky, and through June, $166 million. And we fully support KHA's efforts to extend this to the outpatient payment methodology. They've been talking a lot about that, and we fully support that effort. We also have multiple quality bonus payments that are available, 11 for physical health and 6 through behavioral health. But what we were most excited about, and I promise I didn't talk to the previous presenters before we came in here, we actually have just launched a value-based contracting initiative that's upside only, no risk for behavioral health providers. And there are going to be initiatives within that where they can earn extra dollars, and we've really been out pushing it hard in the rural communities. Next slide. In this slide, I'm not going to go through it, but it's available for you guys, and it shows the details of that plan that we've created. And with that, I will pass it to Dr. Patel.
Good morning, esteemed committee. I want to thank you for the honor and privilege to be able to come and present our data, outcomes, and our value proposition as an MCO. And so I very much appreciate Senator Carroll and Senator Alvarado's commentary in the previous presentation. What we aim to do today is talk to you guys about population health, health equity, and quality outcomes as we try to be good partners for our providers and for the state. And so our number one way of helping our members is our care management programs. It is how we connect to our members. It's a way of life for us. And it is the number one tool that we can use to impact our members. And this is very different than what a provider does. A provider sees a patient, impacts the care of one patient at a time. Our care members, our health equity programs, and our quality programs impact swaths of patients, swaths of members, and that is its own unique value proposition. Care management data analytics tool we have developed internally, which is Kentucky market centric. We use this every day as a data driving tool to help intentional outcomes. And one of the outcomes that we've had is in our diabetes program, inpatient visits per 1,000 down 26%, ER visits per 1,000 down 27%, very big numbers. Our healthy weight program, inpatient down 33% and ER visits 23%. And so two very basic elements of improving the overall health of Kentucky citizens, high impact. Something that's really important, probably also alluded to in the previous presentation, our complex medical pediatric care management, the site of service for these members. Very important. We want to decrease where they're getting care and increase where they should be getting care. And so if you look at inpatient ER, ambulance, land, air, and water, down anywhere from 41% to 73%, ER only down 5%, but a place that we continue to assess every day. But what's really important to highlight is where they're getting care. Increase from anywhere from 4 all the way up to 75%, home, office, outpatient hospital, FQHC, RHC, and CMHC. So we are able to help navigate our members of the Commonwealth to the right section of care, which is not necessarily something a provider can do on their own. Next slide, please. Improvement in the member health care management continued. Something that we have realized is we do know what we need to improve on. We need to improve on health equity, population health, quality, and readmissions is a big part of that. And so we have a readmission reduction task force that meets monthly, but the work is done daily. We have a daily algorithm that's claims-based and clinical-based. We run that list every day, and we reach out to 100% of our discharged members. We may be the only MCO that does that. And what is the impact of that readmission reduction task force? We've been able to reduce readmissions in a lot of our high-end medical conditions, from sepsis, hypertension, respiratory failure, and COPD. Diabetes readmissions are down. But what I will call out most importantly is in that bottom right for you guys as well, mood disorder readmission, schizophrenia readmission, and alcohol-related disorder readmission, anywhere from 2 to 5%. When you think about when you have hundreds of thousands of patients in a program, that's quite a bit. And why is that happening? Is because we're touching every member every time. And what I will call about these care managers, they're a special sort. Why is that? Because not only do they touch members where they are for care management, care gap closure, they're quite agile in being able to pivot during crisis. When we had a special nutrition formula crisis where phenylketonuria patients needed to have their formula, and we had confusion from the formula being switched from pharmacy to DME, our case managers pivoted quickly. We were able to help 100 families in a very short time. And you know, PKU children, they have to have that special formula, otherwise they will be in a hospital with a deathly condition. Very important to be agile in that nature. And then, Senator Carroll, we want to thank you for alerting us about the infant formula crisis. We activated our team right away, and we were able to help 100 families very immediately. And I think these things are important, right? We're not just improving quality, but we're meeting members where they're at for the needs that they need, because health often goes beyond just medical care, and we understand that at WellCare Kentucky. What I will call out is when you impact members in such a deep way, they tend to want to gravitate to this work. Brooke Hall, along with Mike Burns, were heroes, but Brooke Hall was a Medicaid beneficiary. She was helped by WellCare in the past. Her children benefited. Subsequently, she became a care manager in our program, and now she is actually a supervisor on our team. She has grown into that role. She's committed, and it's a great story for us to tell. Next slide, please. We continue to really use that tripod method: quality, health equity, and social determinants of health, and population health with case management to really drive outcomes. We have put a lot of investment, time, and effort into our quality team. It's 50 staff strong. They identify care gaps. We lovingly call them QUIPAs, Quality Practice Advisors. They're based regionally and geographically based on need and where our members are. So they're member and provider facing. They're responsible for 2 to 4 HEDIS metrics. They design, implement, and operationalize these metrics in partnership with providers. They're not meant to be any administrative burden to these providers. They're actually meant to be of assistance. And we continually assess those programs. And these members, they also work with the member to really understand, are they getting the benefits they need? Are they getting the experience they need? They send CAP surveys. They follow up with each member when there is a deficiency in that CAP survey. And we outreach to members during times of crisis, during the floods, during the tornadoes. And this is something that we use all of this data to drive and assess programs going forward, particularly in the SDOH arena. Food, housing, homelessness, and transportation, which I will discuss in some later slides. As Corey alluded to, we understand the administrative burden that behavioral health providers are facing, our medical providers are facing, and in lieu of trying to partner with them, we have come up with some quality initiatives to help them. We have 25 new behavioral health initiatives in this coming year. We agree that COVID has unmasked, uncovered, and really shown us the real prevalence of depression, anxiety, substance use disorder, and it's gotten worse. We 100% acknowledge that. And so some of the things that we want to work on now, non-compliance regarding post-discharge follow-up from behavioral health, adherence to antipsychotic or antidepressant medication, metabolic monitoring. We know these medications can have side effects. And then members with opioid prescription from multiple providers, we do think that's a space that there's tremendous opportunity for improvement. We have a bonus payment program. And let me tell you a little bit about this bonus payment program, why it's important. If providers perform screening for target percentage of members, we pay a bonus payment. There's 2 thresholds, 81 and 85%, quite high. However, in addition, for every screening, even if the provider fails to reach those thresholds, we still pay them. So this is actually a glide path to performance excellence. Start with participation first, then we get to excellence, right? And so this is how we show that we're a good provider member partner. And then we also have the same type of formula for physical health around childhood obesity, breast cancer screening, cervical cancer screening, immunizations, and obesity. So I think when you think about all of our programs kind of in aggregate, it's well-intentioned, well thought of, and it's meant to be member-facing, member outcome, but also in partnership with the provider. Next slide, please. I would like to talk more about substance use now. I think this is something that's very important in Kentucky. Like we have a readmission reduction task force, we have an opioid task force. As it was alluded to earlier, there is a tremendous amount of data that exists in the MCOs. Well, we use that data, and we use it wisely and intentionally. We're assessing that data daily, sometimes multiple times a day when it comes to substance abuse. We create report cards for our members on the risk of continued opioid use, members who are compliant with pharmacotherapy, and who's received counseling. Members who have prescription for Narcan, because that is a direct correlation with if you're going to have inpatient utilization or ER utilization. And so we identify our members, we reach out to them, and we put them in the right place for the right level of treatment. And so if you look at our percentage of medication-assisted therapy by month, always greater than 70%. For the most part, going back to 2019, that's an industry standard. We understand Senator Alvarado is very passionate about substance use disorder. We'd love to talk to him about his ongoing thoughts about that. What I will highlight is in March of 2021, with the advent of our opioid task force, I want to show you some of the outcomes that we've had. You will see in this slide here, members with opioid prescription members per thousand, huge decline and sustained performance over time since that time. And then if you look at the bottom, 15-day supply in a 30-day period and 31-day supply in a 62-day period, also significantly down when you think about members per thousand. So great work. This happens not in isolation. It happens in partnership with FQHCs, behavioral health entities, providers in the field, and with our case managers. Next slide, please. And to wrap substance abuse disorder with a bow, if you look in March of 2022. As I called out before, with the advent of our opioid task force committee, you will see members with OUD in the last 180 days also going down. So significant impact there. And Narcan prescriptions in March of 21 going up. So you see number of new diagnoses is going down, utilization going down, and prescriptions of Narcan going up. All really, when you wrap it up, significant impact to the members in Kentucky who have substance use disorder. And in addition to that, part of our success is being able to reach a macro amount of members, and we've done that through telehealth. As Corey alluded to earlier, there's been a number of studies. There's a study here from the Center by Medicare, CMS data, published in the American Medical Association of Psychiatry, which I believe to be a very reputable journal, that showed the lowered odds of experiencing a medically treated overdose when using telehealth. So the stigma of using telehealth in behavioral health has been dismissed as not accurate now. I'd like to now pass the presentation to Darren Levitz, who is our Director of Member Performance. Yeah.
Thank you, Dr. Pell. Great numbers, especially during the pandemic. Thank you, esteemed committee members, for allowing me to present on some of our efforts to improve our member health. And the way that we do that is through community engagement, and the way that we know that we're successful is by measuring outcomes, which I think is very unique to WellCare. One way that we do that is through our Community Connections Helpline, which is available not only to our members, but for all residents throughout the Commonwealth. Our database is compiled of literally hundreds of thousands of federal, state, and local resources. They are built and maintained so that when we get calls from people, we're able to respond. In fact, 99% of the people that call in are provided with resources on the spot. We know when we're calling in, they're not calling in because they said that, you know, in 2 months, my rent is going to be due, or in 3 months, we might be hungry. They're calling in because they have an emergency at that time. And we know through our experiences, when someone's calling in and saying, hey, the power's going to be turned off today, that very likely that's not the only crisis and issue that they're dealing with. So we take the time to work with them to find out what other needs that they may have. And we are proud that we do provide those resources on the spot to them. You see that through our numbers that over 17,000 people called in last year, and we provided over 42,000 resources to those recipients. So, you know, that sounds great, but so what? We gave them resources. Well, we measure those outcomes. We measure the programs that we provide to our communities, and we see that providing these resources, that they are 5.5 times more likely to visit their PCP after receiving services. They're 1.4 times more likely to have a better blood sugar test, and that they are 1.7 times more likely to improve their overall functional status. So being able to measure those outcomes is something that's very profound and I think unique to WellCare. One thing when I began working with the community engagement team about 3 years ago was to take a new approach. And I said to the team, and I'll say to this committee, if I was to say today that we were going to do a food insecurity program, does anybody have a problem with that? Well, that's like asking, is anybody against motherhood or apple pie? No one's going to shake their head at that. But I've lived in Kentucky my entire life. And in those 51 years, as you guys know, that Western Kentucky is very different than Eastern Kentucky. In fact, all 120 counties are very unique unto themselves and have very unique needs. So we began not just going with hunches or, hey, this sounds like a good idea, but let us use the data to drive what type of programs we put in each of those 120 counties. Let's do things that are going to most profoundly affect the health and well-being of those individual residents. So what you see on this slide is a quick snapshot of one person's territory. And as I said before, what if we said, let's do food insecurity? Well, yeah, that might help. But in this example, we looked through using public and proprietary WellCare data that we analyzed in Fulton County. The food insecurity was not the greatest need. It was quality of housing. It was crime and violence. It was environmental conditions. So we focused our efforts, our dollars, and our team efforts to address those needs and provide community-based partners to those community engagement team members to go and work with them in tandem to address those most salient needs for the people in those communities. And that's how we're going to drive outcomes. It's going to be by working with them to find out what they need most and then making that barrier to health and well-being go away. So let's go through a couple of quick snapshot examples of those. Hotel Inc., who's a longstanding partner of ours, they provide a safe and stable home environment for people. And in working with them for people who are facing homelessness, we've seen a 10% reduction, quantifiable results, 10% reduction in ER visits, and 18% reduction in flu-related visits. With Welcome House, which helps with transition people from housing uncertainty to housing stability. Again, another important need within that county. 22% of those members have found and maintained housing, which we know is essential to improving health. They're not going to see their PCP if they're worried about not having a place to live. We've seen a 48% of those members subsequently visited their PCP. So again, we know that if we provide stable housing options, that those people are in turn going to quantifiably live better and healthier lifestyles. Strategies to ensure health equity. And I'm going to turn this back over to Dr. Patel.
Thank you, Darren. So this is a very important slide for us. This is our foundational slide of how we think about social determinants of health, population health, and how we use our data to drive outcomes. And as Darren alluded to about food insecurity has a lot of different faces, just like every county has a different need. Food insecurity can show up as hunger, a very basic, primitive need. Then it's sustainable food source. Do you get food Monday to Sunday? Do you get it breakfast, lunch, and dinner? Is it hot or cold? Can you get it in time for when you need it? Then the next step is food as medicine, food prescription, which is a very much in vogue thing now, medically tailored meals. Can you get a meal for your particular condition, hypertension, diabetes, obesity, so on and so forth? And then the panacea, food literacy. Do we empower people to pick and choose the food that's appropriate for them? Is it accessible all the time? And they don't have to worry about hunger. And then if you have all of those things, then you can start to worry about what comes underneath. Social inequity, institutional inequity, living conditions, behavioral risks, disease and injury, things that worry all of us. And then we talk about policy. And so we really think about this in a multi-axis format, food insecurity on one axis, solutions on another axis, and then these social determinants of health on a y-axis. And then we use our data to point through where we want to put resources, programs, emphasis, and then measure for outcomes. Next slide, please. And so thinking about that foundation and that framework, we'll talk about some partners that we've used in the past. Black Soil Kentucky, it reconnects Black Kentucky members with cultural heritage. It provides fresh food for the Moms Initiative, meal prescription, and delivered meals. And what is important about Black Soil is we think that you have to pick partners who are going to create sustainable solutions, not a solution at one point in time, which is where we tend to think about how we want to do things. Need more acres, food is medicine. They provide 40 weeks of fresh food with meal kits for pregnant women. We think maternal health is a tremendous place for improvement for us. And when we think of our role as a partner, we think of the convener model. People who are very knowledgeable about community health needs assessments understand that the convener model is connecting two partners to accelerate and amplify health outcomes. So Need More Acres was connected to Hotel Inc., which we had discussed in the previous slide. so we could do some pilot projects for our refugee population. And so that is one of the roles that we can play as an MCO, as a good partner. And then Fresh RX for Moms, continuing to promote healthy food habits and sustainable food sources for our moms. And we don't just go out and ascertain partners. We embed this work, this culture with our care managers to really address for homelessness, address for housing, address for food insecurity. And some of the projects that we've done is really helping our refugees really find 360-degree wraparound services. We also have members who are matriculated back into the community from the penal institutions. We reach out to them, and we work with their parole officers to ensure that they're matriculated into the most appropriate programs for them so they can be successful rematriculating into society as a whole. So this ends our core presentation. If the committee would like us to present additional information, we would be ready to do that.
Thank you. I appreciate the information. One of your earlier slides, well, before I get to that, can you go to slide 19?
Absolutely. Pardon me. Here we go.
Can you elaborate on that one a little bit as to what we're trying to focus on here? Obviously, I understand the health outcomes, and the darker the green, the worse the outcomes, but how does that correlate with health factors?
Sure. So the data that we use on this one is a couple of things. Number one, we were looking at health factors, which a lot of times were simply economic. You know, where do we see the greatest incidence of poverty, where we know that there's going to be greater needs? We are actually taking that to another level. We're now including socioeconomic in other barriers along with those economic needs to determine where we need to be focusing those greatest efforts, because we know where the need is and what those type of needs are is where we want to imbue our efforts. Where we're seeing the outcomes is not surprising. Where we're concentrating most of our efforts, we're seeing the greatest outcomes and improvements that we've quantified and showed you examples of that in the slides that followed.
What's interesting, and to use a medical analogy, I think we focus a lot on treating the symptoms of poverty, such as food insecurities, housing, and so forth, but we never address the core issue, which is poverty. Have you all had any discussion about that, about how you could possibly impact that?
We do. We have a number of programs that we work with. Our WellCare Works is one such example where we provide and work with our community-based partners and members directly to provide them with job training, to provide them with resources of how to interview, how to write a resume, basic financial skills, how to open a checking account, how to balance that, how to apply for credit, and other life skills that they're going to need. One story that I like to tell is I came to the senior leadership team last year when we were discussing our value-added benefits. And I said, I've got a value-added benefit that I want to suggest. It's going to cost us anywhere from $250,000 to $500,000, and it's probably not going to get us a single member. And they said, okay, Darren, tell us all about it. And I said, we need to provide state-issued ID. Now, you scratch your head and say, what does state-issued ID have to do with healthcare? Well, without an ID, you can't get that checking account. You can't rent an apartment, apply for a loan, get a job, any number of basic things that we probably all take for granted. But something as simple as a state ID can make those problems go away and help them graduate through that system and eventually get out of the Medicaid system. So we have a number of programs, educational programs, such as providing people with GED, starting earlier, a value-added benefit that we had this year. We noticed that many of our members fell behind in their education during the pandemic. So we provided hotspots and free internet for a year. We provided tutoring sessions, virtual and in person, for people. All these things to help them get those building blocks so that they can become productive and they can graduate out of the system and become self-reliant. Those are just a few examples from what member experience does to help solve for that.
How do you coordinate that and communicate that with county governments?
That is the job of our community engagement team. We go through literally thousands of meetings throughout the state to make sure that they understand what resources are available. Sometimes they get the opportunities to present. Sometimes when they hear those applicable concerns, they're able to stand up and say, we have a solution for that. So we do work very closely with governments and other community-based organizations to make sure that those resources are well promoted and understood.
I have one more question, but I'll hold it to the very end. With that, Representative Wilner, you have a question, comment?
Thank you, Mr. Chairman. So just bear with me here for a second, if you would. I'm just trying to, so prior to these presentations that we've had all interim, my idea, my main source of information about MCOs was the provider concerns that we've heard from this committee, that we've heard from many people testifying, that many of us have had direct experience and certainly hear from our constituents. But then when I hear the presentations from the MCOs, what I get really is a picture of a broad, systemic kind of social safety net agency. So I guess, can you help me understand, like, how important is that individual provider piece to the overall mission that you have and the overall systemic kinds of programs that you're doing?
Representative, that's a fantastic question. I'm a practicing pulmonary critical care physician, and my wife is a psychiatrist. And so I very much understand the role of the provider in dispensing healthcare to members one at a time. But the drivers of health, what Senator Meredith has alluded to, the things that drive bad outcomes is not always that medical condition. It could be a living situation. It could be a ride. It could be a domestic situation. And the safety social net that the MCOs provide is broader than delivering the healthcare. We are here to enable the healthcare piece, but we're also here to provide everything around it so the provider can dispense the healthcare piece and they don't have to worry about all of that other stuff that comes with taking care of the drivers of health, right? I do feel like let's use a diabetic patient, right? A diabetes patient needs a podiatrist, needs an endocrinologist, needs a primary care physician, might need some health coaching and counseling, and then needs medically tailored meals. A provider, a physician cannot do that by themselves, especially if they're on pen and paper still, right? And so our care management programs, our technology-based healthcare tools, our connections to nutritionists, we provide everything else. And so the credit for the outcome is, on everybody, right? It is an interdependent model that you need to get that outcome. It cannot just be based on the provider. And there are opportunities for improvement, absolutely. We own that piece. But I do think the MCOs play an intimate role, particularly in Medicaid. I think in other lines of business, maybe a little different. But in Medicaid, we think of the drivers of health, not just the actual dispensing of the health care. And so in that way, we're different.
And I'll add to that. There's an old, kind of yarn within healthcare that, you're not going to see your PCP if your basic needs are not being met. And we know that if you're worried about making rent, we know that if you don't have food in there, you're not going to go and get your annual dental checkup. It's just not on your list. You're not going to get your mammogram. You're not going to do those checkups. And a lot of times, and we work with some great partners within the Kentucky Center for Excellence of Rural Health. When gas was up to $5 a gallon, we had conversations with Dr. Fran Feltner down there who told us that there are mothers who are making the decision, specialists, were 30, 60, 100 miles away. They couldn't afford to drive there sometimes during the best of times. When gas got to $5 a gallon, they were making decisions. Do I feed my family or do I go to an appointment? Well, what that mom's going to decide every time. So as an MCO to go through and provide grants to them to say, let's make sure people are going there. You know, through the generosity of this committee, you know, prescriptions are no cost to Medicaid members. But if they can't get to the pharmacy, they're not helping them sitting on those shelves. So those programs that Dr. Patel was talking about in those other things within our community engagement team, we're making sure that those societal needs that sometimes are barriers to that care are eliminated, so that what the doctors want to happen in med adherence and all those other things, that they can actually do. Thank you.
Senator Carroll.
Thank you, Mr. Chairman. And gentlemen, thank you. And before I ask my question, make my comments, in my experience, WellCare is at the upper end of as far as MCOs go. And I know that you all are aware of the conversations that we have in these committees. Mike is here, and Mike is a tremendous asset to your organization. I want you to know that from my perspective in interactions with him. It seems, in building on what Representative Wilner asked, it seems counterintuitive, counterproductive that we consistently hear the same issues from provider after provider after provider after provider. Does it not? And I'm not saying that you all do these things. It's different with each MCO, but it limits the requirements that the MCOs put on providers. And please forgive me, sometimes asinine things that are pulled are counterproductive to you all's success when you look at all these other things that you're doing, because that's at the base of the service. And if providers can't maximize their efficiency, their effectiveness, that's going to limit you all's success. You all are in an industry that's not very well respected in this Commonwealth by many in this legislature. And if things don't change, there's a decent chance at some point we're going to get enough support that some of you are going to be gone. And that's just the hard facts. Do you all see that the industry is succeeding? What do you all do to cut through some of this red tape for providers? And I understand accountability completely. Got no issue with that. But it's just ridiculous. Some of the hoops that and some of the requirements. I mean, you all heard it this morning. Mm-hmm. There's no excuse for that. No one can justify that. So what's your response to all these things, the reports that you all get? What makes WellCare different in this area? And if we were limited to 3 MCOs, what would make you all different in addressing all these issues that we get every meeting we have?
Absolutely, there is room for improvement, but I will tell you the ultimate goal. You know, as soon as I got here, and I will tell you guys, and I don't try to just throw this out there because I think it's going to be great to hear. I've been in managed care 2 years. I was a hospital administrator in hospital administration 20 years and a hospital CEO for the last 8 of those. So I've heard the stories. I was on that side. I used to meet with MCOs myself. Absolutely, I think there's a symbiotic relationship and one that can improve. But in regards to the specific comments we heard this morning, the audits, we don't enjoy those any more than anybody else. Currently, there is for behavioral health, there is no PA process, but we are held accountable. We get audited by DMS and CMS. What are you doing to manage these dollars? Well, since there's that, the only place we can look is on the backside. So we do not want to be an administrative burden. And honestly, the first health system I met with when I came to Kentucky in February was Owensboro Health. I went and met with their leadership team, and he asked me, the CEO there said, "How do you define success?" I'm like, "When you don't say my name." Because typically, I've been in your chair, and when we're talking about MCOs, it's usually not in a good light. So I want to be the smallest administrative burden, and quite honestly would prefer not to be one for the providers on this committee and sitting in this room. So there's absolutely room for improvement in ways we can work together to get better.
And I appreciate that. It's a step forward, 2 steps back, and it just doesn't make any sense that we can't streamline some of those processes and standardize some of those processes, and really the cabinet, and we've talked about this for years, we need to be consistent with the standards and the requirements for each MCO. We shouldn't have 6 sets of rules. And again, I could play the tape, and 6 months when we have other meetings, play it again. It's the same conversation, and it never changes. Thank you, Mr. Chairman.
Thank you, Senator. Representative Shelton.
Quickly, and thank you, Chris, for letting me know that about you. Just a couple questions. Dr. Patel, you said you're a practicing physician, and you're saying that you don't see the same kinds of things Ms. Turner sees.
Oh, I do absolutely
in
see
the
that.
insurance billing.
I do absolutely.
Okay. I misunderstood.
No, absolutely, I see it. My wife is a practicing psychiatrist, and she has a large team of LCSWs, and we see the same problem. She works for a not-for-profit, and it's a tremendous burden. It causes burnout. I also think that we have an issue of new behavioral health therapists, providers coming into the industry. More are retiring, less are coming. And so there's a lot of different nuance to solving that problem. This is one nuance that we have to solve for, but we also need to solve for how do we get new folks to come into that industry that are going to stay for 20 years. And so there's a lot of different things to solve for there.
Well, just generally speaking, you spoke of like a tripod earlier, right? Where the members are always going to be first. There's nobody in here going to deny that, right? But I would challenge you, Chris. Maybe you're the guy in charge. I'd go to a quad. Go to a quad. Put the providers in some level of importance, because what's going on here? There's a difference between managing care and providing care. And you're managing care, but when it comes to providing care, that's going to fall apart if you don't get rid of the barriers when it comes to receiving payment, reimbursements that are way lower than Medicare allowables in many of your services. And used to years ago, and I think the doc will attain to this, is we used to think if we got Medicare allowable, that was like our cost, right? We would think, well, we'll ink by. Now we're seeing, and WellCare, quite honestly, you're well below Medicare allowables on a lot of services. So there's a lot of factors to that. So I don't want to blame you just specifically, but I would suggest that if you will put as much, let's just say whatever second, third, maybe third and fourth, just put it in the equation. And say, you know what, providers should be paid maybe within 30 days at a reasonable reimbursement. And when they call about prior authorizations or other questions, they should have a support team on your staff that picks the phone up and talks to them and makes it happen. Because it sounds to me like in every other area of your company, to say something positive, it is happening. You know, you are getting some good data. You are getting some things. But what you're doing, and that's why the same complaints exist year after year, because we feel like the MCOs are getting to that level just right at the end, washing their hands and go, okay, we've managed it, now y'all provide it, good luck. That's what it feels like. So thank you very much, and I hope you'll put some emphasis on that, please. Thank you.
Thank you, Representative Shelton. Last question, comment for Senator Alvarado.
Thank you, Mr. Chairman. Thank you all for presentations. I got a few questions for you. On the member churn in ER, the very first slide you showed us, how much of that, a big drop in ER visits, big drop in PCP visits, and I appreciate that it's data and you're going to report the data, but that's all a result of the pandemic, clearly. I mean, a lot of people were scared to death of going to ER visits, so I'm wondering how much of that you guys are taking credit for versus actually pandemic causing a lot of that.
It was actually we had a downward trend even before the pandemic, and the utilization, you're right, it went down dramatically during the pandemic, but we were already seeing a downward trend.
The members' access to providers, the next slide that you got, you guys are showing that, and appointment availability. Everybody's come in here saying they're meeting those. I don't believe that. and I'll be perfectly honest. You guys are going to say we're meeting it. I'm going to say I call BS on that. As a provider, I've got people within your guys' services. I can't find specialists willing to see folks. And these are people, towards even closer to Louisville, to places where I provide services. Try to find a GI specialist, 2 months, 2.5 months, 3 months to see a GI person. Primary care, people call me all the time. Hey, doc, who would you recommend? Yeah, listen, I don't have an appointment for a year as a primary care provider. So a lot of these numbers, I don't believe them. I know people that do audits on this privately that are not insurance companies, that are just patient advocates who have data that shows that none of this is true. And again, all the MCOs have come in here saying we've got great networks. I don't believe that. I think you guys need to go talk to some of the folks on the ground. You might have people that call on your behalf to say, hey, can I get an appointment and all that? I don't know how that works, but I tell you, I'm a practicing doc. I saw somebody needs a GI appointment. They've got them set up for December. And I'm like, they need to be seen now for and they said, well, that's the soonest they had for this individual. So this isn't accurate. I know we're hearing it from all the members, not just you guys, not just to call you guys out, but none of that stuff is accurate. I don't think it's really true. And I think you need to go out there and talk to a lot of the folks. And there's other advocacy groups who are going to have their own data that shows that's just not accurate on that. I know you had the Improving Member Health Quality team, the one where you said you're kind of rewarding doctors for filling out forms and doing that kind of assessment. I got a packet from you all. It had 8 patients in there with a form to fill out saying, we'll reward you if you fill out this many of them. One of the 8 was my patient. The other 7 I've never heard from before, don't know who they are. I shredded them all, threw them away. Because I had only one person that was there. I'm thinking, do I need to spend the time to fill this out? They don't know who my patients are or not. Now, I'm in long-term care, but some of those folks are there long-term, and I'm going to be their main primary care doc, and I see them every month, and I do that stuff. But of those 8 that I received in the packet from you all, only one of them was actually my patient. Now, am I going to call to say, hey, can you correct? No, I'm not going to take the time. I don't have the time, frankly, to call and say, can you fix this? Can you make sure of it? Because we've seen these kind of programs before. I'd rather see you go to an ACO model, which is what we've been doing now for, 20 years. Medicare has done a lot of that stuff, where you can bring in providers and say, if you're going to be in this network, show us how you can reduce these costs and do that stuff instead of saying, here, fill out a form for me, make sure you cover these things, document it in your record so we can say that we've checked this stuff off when the patients you've got down for me are not even my people. So I don't know, maybe Dr. Patel, you see you put your glasses on, you probably want to comment on that.
Very much respect your commentary. I would wholeheartedly agree on two things, right? So there is member churn. I think the data doesn't always matriculate down to the provider in a timely fashion. So I think that's an issue when you go to an ACO model. Attribution is at the beginning of the year. So you would alleviate that issue. So we would highly support that. And then in terms of the specialists, we also see that as well. I think what we would say is members have access to those specialists. The timeliness of that access is an area of opportunity for all of us to try to work through, right? I do agree, GI, radiology, vascular surgery, there are those specialties in the Commonwealth. They're just not available in a timely fashion. And so those are 2 different things I would say.
Sure, and that's why you had the slide that said appointment availability. That's why those numbers to me are not, I mean, see them clinically. I can't get people into specialists. I have a hard time finding folks that are willing. There's a lot of factors for that. On the SUD front, on efficacy tools, we just passed a bill recently. We were getting rid of prior authorization for MAT, right, for medication-assisted treatment. Some of our legislators were concerned that people were just writing prescriptions of Suboxone, giving them out, a lot of diversion, no mental health being provided. We passed a law requiring MCOs now to start tracking that and reporting that to the licensing boards, for both the Board of Nursing and the Board of Medical Licensure. I'm curious if you guys have been doing that. I mean, as you're seeing, you got providers out there that are doing the right thing and some who aren't. Are we reporting that information to the respective boards now?
We are.
And I said, I know you guys don't want to be the ones to report that. I'm going to have to be contacting our boards to make sure. Because I'll be curious to see what those numbers look like. What was reported off the record for me was from multiple, not just not you all, multiple different MCOs, was on the order of 60% of our providers weren't doing any mental health that they could track or see. I found that surprising, but I don't have the data to look at. So I'll be talking to the boards to kind of get an idea where we're at on that, because they need to make sure that they're following regulations. Other thing, I'll say it, and I know Mike Reitnauer was mentioned earlier. When I first came here, you guys were the worst performer of all the MCOs. So you guys have made a lot of strides. It's been 10 years for a lot of this stuff. So I know we hear about a lot of the efforts being made on trying to improve all this stuff. again, the data overall from as a state, where we stand from where we were 10 years ago, we really haven't moved at all. And that's been the argument we've had when we've brought in all the MCOs. You guys have improved a lot. I think you've responded. You were, I think, threatened by a previous administration to be removed entirely as a provider because the job you were doing was not good. You made a lot of strides. I commend you for that. So things are improving. But just in terms of that, I mean, maybe you can comment for a lot of these plans, all these things that we're doing. Hey, we're going to try to improve all these different things. We've had 10 years of experience now with WellCare, and we've seen, and you guys have the bulk of the patients within the Medicaid system, but yet our overall rankings as a state really hasn't improved. And a lot of that is from the Medicaid population. So I would charge you with that. I mean, as you're looking at, making some of these improvements on diabetes and outcomes, that's what we've been, when we had expanded Medicaid, all these promises for MCOs was thousands of new jobs, all this improvement in healthcare outcomes, things are going to be great. What we've had is an added level of bureaucracy and frustration for providers and really no improvement in overall outcomes for folks, which is my concern. So you guys have improved. I'll give you that much. You're no longer the worst spoken about, to Senator Carroll's point, amongst the MCOs. We just want to start seeing some results on some of these things. And I know it's tougher, and it's going to have to be some different innovative ways to work with local governments and providers really, instead of on a retroactive angle, is to look at an ACO model where you say, here's where your current baseline is. We want to get you here. We'll reward you financially if you push this. Because if they're allowed to be the ones to be innovative and do their own things to improve the outcomes, you'll have a lot more buy-in. Providers will be willing to work with you more than to say, yeah, you did all this. We think you're robbing from us. Prove to us that you didn't. I mean, those things are just not good approaches. And you guys are both, active provider, previous provider, Mm-hmm. That's what I would encourage you to look for if you're going to be innovative on this stuff. Thank you, Mr. Chairman. Appreciate it.
Thank you. Just a quick anecdotal experience. As you know, my son is a primary care physician in Grayson County. And I think he's seeing everybody in Grayson County because people come up to him and say, I see your son. Ran into a couple last week, as a matter of fact, at the event. They said, is Dr. Meredith your son? I go, well, why do you ask? But yeah, well, he's our physician. I said, well, that's great. And they said, well, we haven't seen him yet. We have an appointment. And this is family medicine. We have an appointment with him first week of February. So it reminds me of that anecdote that, if you believed in averages, no one would ever drown in the Rio Grande River because average death is like 3 feet. So, yeah, I think this number is a little bit suspect, particularly for rural communities. I think it can be skewed. I said Alvarado will be the last word, but I'm going to yield that to Senator Carroll.
Thank you, Mr. Chairman. And one thing I want to close out with, you all looking at all these programs and services that you do to benefit your members, going through the process of starting a new program, a service that's badly needed in this Commonwealth, and that's autism services. There's no help from you all. It's an adversarial relationship. There are competing interests. It would be great that as someone trying to set up a new business, that I could rely on MCOs to come in and help to ensure that as a provider, I could sustain that program. And it seems in this field, there are a limited number of providers, and we need far more than we have in this Commonwealth. It seems that it would benefit MCOs also to be a resource rather than an adversary in helping people who want to open up businesses for a lot of different reasons. Employment, poverty, because it provides jobs. Our center alone will provide probably 40 jobs in our community, ABA being a one-on-one type therapy. Why do you all not do anything like that? Wouldn't that be a good investment of your money?
Absolutely worth looking into. So, yeah, absolutely. Love to have a conversation with you about it.
Yeah, and I'm not talking about just me. There are lots of folks that, I mean, you've heard these folks talk about how they're going to end up closing their doors if things don't get better. Would it not be worth your time to, with all of these places, what's going on? Why are you going to close your doors? What can we do to support you? And like Representative Sheldon said, make it more of a partnership than being about this.
Yeah,
because
absolutely.
from the provider perspective, looking at MCOs, it's all about this. And that's why there's such disdain for most great people that work within the MCOs. Some of the finest people that I deal with work for MCOs. And I love the communications, but the system, the normity, the profit, you guys just don't have a lot of credibility. And we need to change that, or you're likely going to be gone. Thank you, Mr. Chairman.
Thank you. And thank you for your presentation.
Yes,
I want
sir.
to thank our committee members for your attendance this morning and participation as well. Our next committee meeting is November 10th, believe it or not. It'll be the last one of this interim session, and Co-Chair Elliott will be chairing. So we will look forward to that. Again, thank you for your presentation, and I'm sure we'll be talking more in the future. Thank you. We stand adjourned.